Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data, proudly brought to you by Pulse IT News. I'm your host, Louise.
And I'm your co-host, George Margellis.
George, you and I, but I think you more than me, have had a very busy fortnight and I want to hear all about it. So you've been to Barcelona, you've had the conference there, and then you've also had the IT and Aged Care conference in Melbourne. So tell me, how's it been going?
Look, it has been a busy fortnight since we last recorded, but that was actually in Athens that day en route to Barcelona for the Mobile World Congress and Digital Health Wellness Summit. First of all, Athens in winter is awesome, highly recommended, lots to do, far too much to eat, I have to say. We had a great time there. And Barcelona is a beautiful city, but adding 100,000 people for a couple of days does have its challenges. So it took us about an hour to get from the airport to the city, which is about 12 kilometers. So It was an interesting journey. Huge conference. Mobile World Congress is the largest technology conference in Europe. It's actually one of the largest conferences in Europe. It can only be held in Barcelona because that's the only place big enough for it. And there's 9 huge halls at the convention center, which are full of state-of-the-art tech. I focused myself on a single hall. There's Hall 8, and Hall 8 is co-hosted by a group called 4YFN, which stands for 4 years from now. So it's focused on startups. They had over 900 startup booths just in that hall.
Wow.
That'll give you an idea of the size of it. Most of those were sort of pod type sizes and they all sort of demonstrating things, but they actually had a couple of big ones, the Barcelona Health Hub, the Madrid Health Hub. The interesting one was Alibaba. So Alibaba, the company out of China, had a dedicated startup booth, as did AWS, and it was quite interesting. And also there was a very interesting one by the Barcelona Supercomputer Center, which showed a whole bunch of things, including some of the drug discovery stuff we were talking about in past episodes. So lots happening. You know, you could have spent the whole week just looking at the booths.
Yeah, what was your step count?
We did hit 20,000 plus that day, I have to admit, and that's by utilizing all the escalators and lifts we could to try and keep our knees operating. So it was fun. The big thing was there was one day dedicated to digital health. That was the Digital Health and Wellness Summit. That was run by the ECH Alliance, and it was actually held in one of the theatres. So the trade floor was huge, and they had a number of smaller theatres within it. So to give you an idea, there were 3 theatres within the trade floor that just in Hall 8. Each one of those held 300 to 400 people. So it gives you an idea of the size. That event was at capacity all day. They actually had to limit the number of people coming in. So they actually had a queue of people waiting outside, and as someone left, they left other people in. They had a series of presentations. Now, the ECH Alliance were running. So it did have a very strong European flavour. But interestingly, there was actually a very strong contingent from Africa. Lots of interesting work happening in Africa, and they referred quite often to our good friend, Alain Lebrique, and the WHO and the work he's doing there. It was an interesting mixture of things. There were some Americans, but it was very European focused. AI, as always, front and centre.
Yeah. What were some of the key things? Did anything like surprise you or...
Look, the African presence was interesting. The global reach of the ECH Alliance, I mean, they're very strong in Europe, has a contingent quite strong in the US. South America and Middle East starting to get engaged, and they're very keen on Asia Pacific. So there was a representative there from Singapore who's now their Singapore ambassador, and they're looking at how they can make it a global connection. So I think something we should keep our eye on, how we can get those global connectors. And in these times of American uncertainty, I think we need to make sure we've got links with other parts of the world. A couple of really interesting presentations. Our good friends from Estonia, who we'll comment on later, were there speaking about their journey. So it was interesting how, Estonia had to go digital from day one because of the challenges they faced as they moved out of the Soviet Union. And that was a thing. And we should probably have a chat with them because they're progressing very rapidly because of their relatively small size and their digital first nature. Things are moving very fast. There was a very interesting presentation called the 3D Forces Shaping Healthcare, Democracy, Demographics and Digitalization. And that gave some interesting perspectives.
Oh, cool.
Lots of opportunity. Interestingly, and I didn't realize, the RMIT, the Australian University, actually has a campus in Barcelona. So they were there and they were talking about how they work with European groups around joint projects. So Australia seems to have a bit of a play in Barcelona as well. So interesting speakers. great networking opportunities. The ECH Alliance organises some great networking dinners where you get to meet some people. I did spend quite a bit of time with the lady from Singapore. We're looking to see how we can make a stronger Asia Pacific presence in the events going forward.
All right. Yeah, let me know if I can help with any of that as well. That's really interesting.
Absolutely.
The eHealth Alliance through the Informatics Society has been blowing up my phone recently. They've just had a meeting that I didn't attend because I'm in a wrong time zone for them. So there's lots of opportunities in that part of the world that, of course, Australia is quite close to. So then you went from Barcelona to home for 24 hours and then to Melbourne?
Pretty much. Got home on Sunday, spent Monday recovering, unpacking bags, cleaning shirts, and on Tuesday morning, back on a plane for ITAC. So innovation, transforming aged care was for the first time the conference was run by Aging Australia, the peak body. So the old Aged Care Industry Information Technology Council has merged into the peak body. We had over 650 people registered. A little bit of a glitch in that there was a little cyclone up north which caused a few interesting challenges for some Australians, including, unfortunately, our events team was stuck in Queensland. They couldn't get out, but at the last minute, the local team came to the fore and they managed to pull it off. But over 70 exhibitors, a lot of people there, lots of buzz. And we had 3 futurists in our presentation. So we had Catherine Ball, who did a standout presentation about the future of technology and the ethical responsibilities we have around implementing technology effectively. And the last speaker was a guy called Stephen Johnson, who spoke about the future of aging. And again, he looked at how the innovations and the technologies available need to align with the requirements and the desires of an aging population. So we can't just technicalize everything they do in aging. We need to understand the issues of aging. Lots of discussion about the impending reforms. I mean, we have July 1 was mentioned many, many times when the new Aged Care Act comes into place. Lots of discussions about standards. FHIR and Inter-RAI were mentioned a number of times, and Kate did a great presentation around FHIR and its use in aged care. We're starting to see a lot more work around the use of data standards in aged care, managing IT risk, capacity, workforce capability, capacity. There was a amazing speaker on that panel, someone you probably know very well, since it was you that did a great job in talking about the capability building that's required to enable us to get people to use technology. It's not just a matter of introducing the technology, but you need to have the capacity and capability of the workforce to do it. Interesting, the 2 government representatives, Faith Lavaris and Emma Cook, were very active there for the whole time. They spent a lot of time talking to people around their vision of what it looks like. But we actually also had some great presentation by some local providers. In particular, there was one from a group called Multicultural Services of Victoria, a guy called Johan Locke, who looked at their digital transformation journey, which is very significant, and what the associated challenges were. And it's interesting, he's come from a fintech background into an aged care background, and he sort of compared the challenges and the opportunities between the 2 industries and how that went down. So it was overall quite a good session. I think people walked away enthused, keen to carry on their digital transformation journey. But, they said, you managed to make the first day. We did miss you on the second days. I'm sure there would have been a lot of questions you could have asked.
I'm so sorry.
You had to run and catch a plane to get to where you are. Where are you now?
Well, I'm in London. I'm under a blanket because it's freezing here. It's 1 degree. I arrived just over 24 hours ago. Yeah, and I'm here to speak at Rewired, which is in Birmingham. So that conference is so big, they take it out of London as well. So not 100,000 people, but I'll let you know next recording how many people are there. But yes, I'm here for that conference and then a bunch of meetings, including I'm going to Wales apparently. So there's an appointment with someone I know showed off in the diary. And I was like, is that on Teams or? And he's like, no, we're going to go to Wales. So I was like, okay. So after the conference, I'm also off to Wales, which will be fun.
Excellent. That's a health-specific conference, or is it across everything?
It's digital health specific. So 2 days and I'm giving an update on what's happening in Australia. And then I'm also chairing a couple of sessions. I'll talk about it in one of our hot topics, George, but there's some big news here in England that a lot of the conversations at the conference will focus around that, I'm sure. Oh, I have to tell you, I had the best day. So I arrive at 6 a.m., can't check into the hotel till 3. And I've got to stay awake. So I don't know how you go when you headed to Greece, but I find that if I can make myself stay awake the first day and be out and about, trying to get whatever vitamin D I can get in London with the 0 UV here, But anyway, get some vitamin D, walk around. And so I walked around the city. I think I did 20 odd thousand steps that day. But I went back to one of my favorite places to visit, which is the Wellcome Library. And it's completely free library. Anyone can go in. It's sort of like a meld of art and science. So they've always got exhibitions. And, like in the gift shop, you can buy jewelry, for instance, and tea towels that have got anatomy drawings on them or anatomy 3D replicas, that sort of thing. So it's really cool. I love it. Really geeking out there. So I have a reading room with like bean bags and some great artwork. So I just went there to do some work. And then I went into the library part to charge my phone, actually. And I was like, okay, well, that's going to take 20 minutes to charge my phone. I'll wander around and just have a look at medical journals because, I haven't been in a medical science library for many years. And I just had the best time. And I'm sort of bummed I don't have time to go back because I picked up one of the oldest books I saw on the shelf, which is the Edinburgh Medical and Surgical Journal, a concise view, and it's discoveries in medicine, surgery, and pharmacy. Well, this is the first volume, and it's from 1805.
Oh, wow.
I know. I was like, and I didn't have to wear gloves. I just picked it off a shelf. I didn't need special permission. And I was like, this book is 225 years old. And I was really bummed because I was reading through it. And then they called us and they said the library was closing. I'm like, no, I haven't finished my research. But anyway, on the table of contents, I'll send you a picture, George. But I was having trouble reading it. And I was like, hang on, I know this is English, but here's something from the contents page. Cafe of Malconfirmation of the Urinary and Genital Organs by Mr. Atfley Cooper. Let's see, that's another one here. Oh, here we go. On the Pneumatic Defeefes of the Poor by Dr. Badham. And anyway, it took me a few minutes to work out because I was like, what's all this cafe of and what does defeefed mean or defeefy? Anyway, and I realized that in 1805, the letter S in type form, it was a long S and it looks like an F. So it's not cafe, it's cases. And it's not defefe, it's diseases. Anyway, and so then once I worked that out, I was actually able to read this journal and I had so much fun with it. It was just geeking out. So that'll be one of my recommendations. If you're in London and you've got some downtime, don't go to look for a Starbucks. Go to the Wellcome Library and there's wonderful things to see. There was this like dress, a piece of artwork, and I've seen it before. Like I think when I came here a few years ago, it was on display at I think it was where I was like College of GPs or something like that in their foyer. But anyway, this dress and it looks like the beads, like a black dress and really glamorous looking. And when you look closer, the beads are actually birth control pills in their little packets. And the dress was designed as a communication tool to show this is how many pills as a standard, if you take birth control for most of your life, as most women do, this is how many pills you'll take. And it's like something like 6,000. So anyway, I had a great time geeking out at the Wellcome Library.
Cool. So that's part of the Wellcome Trust type environment?
Yes.
Yeah, fantastic.
Yeah, I was wondering if Julia Gillard was going to be around, but I didn't see her.
It's interesting because I remember one time when I was over there and we went to the Imperial College and you sort of realize, hang on, the Imperial College is like 450 years old and it has amazing historical context. And I walked through their library and the same sort of thing. It just blows you away, the historical context of where you are.
Absolutely. It's incredible. And another thing I wanted to let you know, George, is we hear from listeners all the time. And thanks, everybody, to those of you who write to us and talk to George and I when you see us out and about. It's really great to hear your feedback on the podcast. So thank you. But I have to tell you this one, George. So I got a message. It was through LinkedIn. And this guy says that he loves the podcast and that we've inspired him to revisit thinking about doing a PhD in digital health. How cool is that?
So we're doing our bit to make sure the capability and capacity is improving. Good to know.
I know. I was so impressed. So I was going to say, listener, I won't read out your name live on the show, but you know who you are. And if you decide to do that PhD, let George and I know and we'll have you on the pod and you can tell us all about your studies. So we'd love to hear from you.
Absolutely.
Okay. Well, with so much going on, George, should we get into our hot topics?
Let's jump into it.
So I sacrificed being able to attend the second day of ITAC, big sacrifice. I jump on 2 planes and 27 hours later, I land in Heathrow. And as I said earlier, I had another 7 hours before I could check into my hotel. So I thought, well, instead of taking the express train, I'll take the slow train. It's cheaper. And my goal today is to stay awake. So I give myself things to do. So got on the slow train. And you know how in London, they still have the Metro, it's like a free newspaper? Yeah, like old school paper and ink for people who haven't visited London. Well, everyone on the train was reading it because I was basically in the early morning commute. And I saw this headline, Starmer's shock NHS takeover. So yes, the Prime Minister of England, Sir Keir Starmer, had announced he was doging NHS England. Yep, everyone here is talking about it, and it will be a hot topic, I'm sure, at the Rewired conference. So NHS England was set up 13 years ago to remove political interference and to basically put the running of the NHS into the hands of health experts. It's an independent agency, but fully government funded. And under the new plan, NHS England will be progressively closed over the next 2 years, and the Department of Health will resume oversight of the NHS as it did for, 65 years beforehand. Now, sadly, though, it does mean that 50% of the people will lose their jobs. And so there's been a lot of talk about the 10,000 people who are going to lose their jobs. So, first we had New Zealand and now NHS England. Everyone's getting doged. What do you think about this, George?
Doging is now a verb. It's a bit scary, isn't it? We can use that as a verb. When I first saw that story, I must admit I was a bit surprised. I thought they were getting rid of the NHS altogether. And I thought, 77 years of the NHS and they're going to scrap it with a stroke of a pen. He must have spent far too much time speaking to Donald Trump in his spare time. But no, like you said, when you look at it a bit further, NHS England is a relatively new organisation designed to depoliticise healthcare, which sounds like a pretty good idea if you think about it. It's depoliticising a service which is required, I think makes sense. When you dig a bit deeper, you see it has quite a few responsibilities. I mean, it commissions services, it sets standards and guidelines, it does workforce development, it funds allocation, it does public engagement, it drives innovation and research. It sounds like a pretty worthwhile thing. And I thought, well, there's probably a reason why in 2013 they thought it was necessary, because I looked up and sort of said, well, how many individual trusts are there in England? And shock horror, there's over 220 trusts in England. So trying to manage 220 trusts individually, I think would be quite a challenge. So I guess it was a Conservative government initiative, bit of a knee-jerk reaction, I guess, for the Labor government to get rid of it. But I guess they need to then think about, what does this mean to fragmentation? I mean, we complain about our fragmentation in Australia with 6 or 7 states. 220 trusts is going to be a fairly complicated thing to try and coordinate. And without having a centralized coordinating organization around it, I watch with great interest because, again, the UK spends about 11% of their money on healthcare. The NHS England only consumes about 2% of that. So what is the value of a management service within such an organization? I don't want to watch a free-for-all battle by the 220 trusts all trying to get their hands on government funding and fighting with each other and using their own standards for their own systems and disparate technologies. And it should be interesting to watch.
Yeah, it will be. And I'll be able to report back on our next episode as well from Rewired Conference and see what I learned there about it. But I did note in what's been published that Sir Keir has said that he will harness AI to slash the size of the civil service. So again, it does sound very dogy, very Trumpian in terms of being able to, think that we can replace all these people's jobs by AI, which is going to be, we'll be talking about that a lot over the coming years.
I understand the need for cost savings, but sometimes saving costs in one area lead to increased costs in others. And like I said, 220 trusts. And interestingly, the English trusts aren't like us. They're not just regional trusts. I mean, there are subspecialty trusts, there are different primary care and hospital trusts. I mean, it's a really complex structure. And if all 220 of those go down their own unique pathway, trying to have a united, because I saw recently there was an article coming out talking about the need for a united health record. Well, uniting 220 disparate records does not sound like an easy job.
No. So yes, we will watch this space and feel sorry for all those people who are going to lose their jobs, and hopefully they can find new deployment elsewhere. And I'm not sure how you close down an agency progressively over 2 years. It's sort of like that seems a little excessive to me, but at least it's not Elon Musk style where it's like 24 hours.
It is one of those classic dilemmas, isn't it? But when you announce that you're closing something down over 2 years, the good people who are really good at their job will be the first ones to apply for other jobs. So you lose them first, and it leaves you with the people who can't get another job. So that should make it an interesting experience for them.
Yeah, that's right. All right, well, on to our next hot topic. George, you and I, we've caught some long-haul flights recently. So with that in mind, I was interested to see that telemedicine is taking to the skies. No, I don't mean the Royal Flying Doctor Service, although, of course, they're awesome and we should get someone on the show from the RFDS. But anyway, Emirates has announced in-flight telemedicine will be available across 300 planes with a progressive rollout over the next 2 years. They've actually worked with a French company to design bespoke telemedicine kits. They call them stations, but it's in a box. So I think it's like a telemedicine kit. They've spent about $2.4 million US on them. And the kits remind me of that awesome one that Daniel Craig's James Bond had in the car in Casino Royale, for everyone who's seen that film. If you haven't, press pause now, go and stream that. It's one of the best James Bond movies ever, I reckon. But anyway, back to the story. The station that Emirates has designed includes video conferencing, ECG, and a whole bunch of other tools to measure your vital signs. The crew will be trained to use them, and the data is able to be sent to Emirates ground medical support team, which will enable passengers to receive high-quality, speedy medical care in the air. George, Dr. George Margelis, have you ever been called upon for a mid-air emergency?
Well, first of all, I mean, Daniel Craig's self-defibrillation trick in Casino Royale was pretty awesome. I mean, if you can make that work, it's pretty good. But yeah, look, normally when I fly, I don't put Dr. Margelis on my ticket. I fly under Mr. Margelis because, if there was an emergency, I'm not quite sure I'd be the best person to respond with it. There have been a number of calls on flights that I've been on, and fortunately, I seem to always fly with other doctors. So more qualified people have jumped on board. And I was on one flight once when one very lucky patient had something go wrong, and there were 13 anaesthetists on their way to an anaesthetics conference on the flight. So she probably got the best treatment she's ever had. There was a horrific story recently, I don't know if you saw it in the news, of a young couple on their honeymoon who were forced to fly next to a dead body for a large part of their flight because someone passed away on the plane. There was nowhere to put them. So they strapped them in the seat and sort of said, you can have her food as well. She's not having it.
So sad.
It was pretty sad. A very good friend of mine, Dr. Dora, tells me it's an excruciating story she had when she had to provide some care on a relatively short haul flight. But they do have fluids on board a plane, but they don't necessarily have lots of them, and they don't have the best needles. So she spent 2 or 3 hours in the restroom with a patient. The new kit sounds pretty impressive. And like I said, it's a godsend because you think about it, some of these long haul flights, I mean, Sydney to Dubai is 14, 15 hours. And they're now talking about direct flights from Sydney to London, 22 hours. Having real telemedicine tools, so having ECG, having video conferencing. And it just goes to show how far the technology has developed over time that we can do this now in a plane flying at 600 kilometers an hour, 40,000 feet in the air. But it's that core understanding of what good telemedicine is, being able to provide all the clinicians in the process the right information so they can share information in real time. And hopefully we'll never have to use it. I think it's a good idea that they've got them in place. And again, $2.4 million may sound a lot, but that's for kit sitting in the back of a plane flying in the middle of nowhere. It just goes to show how much telehealth has advanced over the years.
So I had a look and did some research, and I found a 2013 study in the New England Journal of Medicine, and it estimated that a medical emergency happens on roughly 1 in every 600 commercial flights. So that's about 44,000 in-flight medical emergencies occurring worldwide each year. So don't panic, anyone. It's only 24 emergencies for every 130 per million passengers. But this must happen all the time. And I know we have lots of medical friends, George, and I was actually surprised. I don't know what Emirates does, but apparently in Australia, I've had numerous doctors tell me where they've spent the majority of their flight, helping a passenger. And of course, they're happy to do it. One person particularly, it was a long haul flight. So she spent like 8 hours helping a potential patient, not sitting with her kids. And I thought you'd get a refund or here's a credit for your next flight. No, it's nothing. It's just the staff saying, thanks.
bottle of champagne if you're lucky, and a pat in the back, and some help washing any body fluids off your shirt, I guess. It's interesting, yeah. That's right. People I've spoken to have sort of said they do it. It's all part of our Hippocratic oath. But yeah, you think you've spent all that money on a long haul flight and you spend most of it in the toilet giving IV fluids, so you might be able to do something back. So note to the airlines, treat your doctors on the planes better.
Yes, I think so. All right, on to our next story. Next, we've got a newly published study which compared 9 OECD countries' digital health strategies. They were evaluated for vision and objectives, means to achieve said objectives, and structures for follow-up. The study showed where the strategies fell down, which was lacking detail when it comes to how they were actually going to achieve their objectives and evaluate their progress. But in kudos to Australia and Estonia, those countries had the most comprehensive detail on tasks, responsibilities, timelines, and follow-up mechanisms. So yay, Australia, and good on you, Estonia. George, you've seen quite a few national strategies in your time, I'm sure. Can we evaluate them without being cynical as to why they don't often reference evaluation on their impact of healthcare delivery, patient outcomes, and system efficiency? I mean, we know that's why we do these things, but often the strategies paint the vision, and that's what this study was showing, rather than actually, well, how are you going to get that done? And do you have the budget? And do you have the people? And who's responsible for what?
As with all strategies, the devil is in the detail. It's what you do with those strategies. It is interesting to see, like recently when the government published the aged care digital data strategy, they also published an associated action plan. So they seem to be learning from past mistakes in that they are developing plans around delivery. Of course, the challenge then is, of course, that plan needs to get budgeted, and that's a part of the challenge. The good news is that we've been following Australian health strategies now for a couple of decades, and they are matured. I mean, like I said, we're up there with the top of the world in the OECD countries, and that includes some pretty big hitters. And if you go back to those early Health Connect documents back in the beginning of the century, yeah, they were very vague thinking about what this means. Now we're starting to see stronger inputs. And part of that's because we now have a much more robust academic sector in the space who are looking at these things and keeping the commercial interests honest in a large degree. And you get a couple of old fuddy-duddy doctors like myself and some others who sit there going, but what does that mean? So I think we are getting there. So kudos to Australia. Like you said, now the next stage is, of course, implementing it. Estonia, on the other hand, is an interesting comparison. I mean, Estonia literally only got independence 34 years ago. They started their system from scratch. So they have an opportunity to start off with a clean slate, which we never had. And as a result, they've got a very strong digital bent. And at the last couple of European events I've been to, the Estonians have been upfront talking about that. We just need to keep in mind, of course, there's only 1 million Estonians and they're in a very, very small country. So they talk about how well wired they are. But when you're literally the size of the Sydney CBD, that makes it a lot easier.
And they've got an open air architecture, don't they, Estonia?
They do, yeah. Look, they're being very open. Like I said, they literally had to digitize out of necessity because they came away from some 50 or 60 years of being under Soviet rule and gained independence, built a digital community. They have a digital citizenship. So you don't even need to live in Estonia nowadays to be a digital citizen of Estonia, which opened them up for business opportunities. A lot of startups use Estonia as their base. Centrally located in Europe, you've got a market of 500 or 600 million sitting right at your doorstep, which always a big help. To put them in contrast, Australia has probably done an awesome job. So kudos to the people we know in Canberra and in the various states.
A lot of them have come on the pod.
We have a federal policy strategy. We have state strategies. We have lots of strategies. So tying them all together is still part of our challenge.
Yeah, that's right. But we're doing good according to this study. And I'll put a link to that in the show notes, of course, as well for anyone that wants to check it out. For our next hot topic, speaking of evidence-based progress, the University of Adelaide just published findings in Human Genomics arguing for more advanced analytical methods to gain better insights into chronic diseases. They're saying that basic descriptive stats aren't enough, that we need machine learning, AI, and real-time data to adopt multi-omic approaches to our studies and analysis. And that's basically because chronic diseases like diabetes or heart conditions are multifactorial, and standard linear analysis just doesn't capture those nuances. AI-driven tools can unearth patterns we'd never see in conventional studies. But to do this requires robust data sharing, ethics approvals, of course, and computational infrastructure. And I love this idea of real-time remote monitoring feeding into these big analytics. George, you're the scientist on the show. Do you want to explain multi-omics to us? And then do you think we're going to be witnessing a massive change in the future of chronic disease management in this age of AI?
Look, multi-omics is an amazing idea. I mean, the fact that the more data we have, the better it is, and that we can utilize that data. And that data can come from genomic data, proteomic data, epigenomic data, understanding the hormones functions more effectively, looking at environmental factors as well as physiological factors. There are so many things we can measure nowadays, and there's so many ways of capturing that data. And now we have tools which enable us to not only capture the data, but store it, analyze it, and report on it. So I think we've come a long way in that we've got so much data to deal with. We are almost overloaded with that data. So we really need to start thinking about how we use that rich set of data more effectively. Now, personally, I'm a big fan of Occam's razor. And Occam's razor is a problem-solving principle that recommends searching for explanations constructed with the smallest possible set of elements. So basically, keep it simple. Try to keep your decision-making focused on a number of elements. But the beauty with multi-omics is that we can now survey all the data and determine which data sets are of most benefit, remove those that aren't, and use those to make decisions. And the reality is that the human body is a really, really complex mechanism. Things like the number of potassium ions floating around in your plasma can affect how your brain works and how your bowel works and how your heart works. And we're just starting to understand that. So I think it's really, really good. Fantastic that our colleagues in Adelaide are focused on this. And I think there's the Institute for Machine Learning down there, which is doing some great work. We really need to focus on that research and make sure we actually have outcomes that are relevant. So I think it's really good that we can get the most bang for the buck out of that data and work out how to do that. And that the fact that it's happening here in Australia, I think, is a great start. And it's a real opportunity for young researchers to start looking into the area of healthcare more effectively.
Yeah. And I'd really love to see, I would hope in the next few years, we can get to a point where me as a patient who's, having a checkup or, I've got something that's been diagnosed, I can give permission, comprehensive permission to access my data. So that like that open consent where I can say, yep, you can use it for research. Yes, you can use it to treat me. You can use it for drug development. I don't mind. But then also, or actually, no, I don't want it to be used for that purpose, but I'm happy for my data to be used for this purpose, where me as a custodian and owner of my own data is just so important. And if we can get there, because of course, EMRs and EHRs and all, like those systems are excellent and much needed, but that's only because we need to capture the data and we need to be able to do something with that data. And to this idea of being able to capture as much data as an individual gives their permission and have it being used by researchers at scale, we should be able to see a significant change, I would think, in all sorts of things, not just diagnosis of disease and understanding of disease mechanisms, but yes, all sorts of things to actually hope keep us healthier for longer.
We've now identified a major challenge for our friends at My Health Record to be able to capture all these data elements and make them available to the individuals themselves. They shouldn't just be sitting in a research database. You should be able to look up your own biomarker data and educate yourself on the value of it. And again, using proper evidence-based routines, make sure people understand how they can take advantage of it. And secondary uses. I mean, we've had multiple discussions in Australia about secondary uses of data. Everyone I've ever spoken to, when I've said, I want to share your data to help the country make better healthcare decisions, I've had very, very few, if any, people say, no, I don't want to do that.
Yeah, that's right. Well, we know our friends of the pod in government do listen to the show. So don't worry, guys. We're not going to expect you to come back on and tell us about your multi-omic strategy for data capture with the My Health Record. Not this week anyway, but we may get you in at a future date to talk about that. And I mean, these are the sorts of things that government and the vendors of health systems as well are looking at constantly, is not just the quantum, but also the breadth and the depth of data that we are starting to expect to be collected about us and to be used in decision-making purposes, not just by our clinical team, but by us ourselves.
Absolutely. Looking at, so we'll put them on notice that we'll have that discussion in the future.
Yes, absolutely. So I want to talk about allied health in our final hot topic this week because two stories caught my eye. So firstly, here in England, the NHS is rolling out an AI tool to predict falls and viruses. It's reported to be 97% accurate at predicting a patient's risk of falling. It's already being used in 2 million patient home care visits a month, monitoring vital health signs to predict worrying signs of deterioration in advance. And it then alerts healthcare staff so they can step in and reduce the risk of hospitalisation. And the second story, which is a different one, but allied health related again, back over to the US, a company called Hinge Health is a startup, very successful one, and they do digital physical therapy. They've just filed to take their company public. Now, we've mentioned before on the pod that there's an awful amount of investor money, like billions, sitting in digital health startups where there hasn't been a big exit with an IPO offering for a pretty long time. Hinge was valued at $6.2 billion US in a 2021 funding round. They've reported a 33.4% increase in revenue for 2024 and a reduction in net losses. Hinge Health was founded by a biomedical engineer and a product guy, and they do comprehensive musculoskeletal care ranging from acute injury treatment to chronic pain management and post-surgical rehabilitation. George, what do you think? Allied Digital Health, hot right now?
Look, I think it's about time that it got the focus it should have. I mean, both of us have an allied health background, and the reality is when you look at healthcare delivery in Australia, anywhere in the world, allied health workers provide a significant part of that care. So whilst we're focused very much on the medicos, and rightly so, I mean, the medicos have a role to play, the services that are delivered by allied health often play a much larger role. And especially now that I'm doing more work in aged care, allied health is, other than nursing, is probably the biggest player there. I think both of these stories are very interesting. The NHS AI tool is very interesting because, again, predicting falls or predicting deterioration is a great way of making sure we deliver care to those who need it when they need it. So the tool they use in the NHS, and from what my reading, it's been very well evaluated and tested in a very large cohort. The challenge with all these tools is scaling them out into the real world. So proper evaluation, proper development of clinical models that utilize the information is critical. And again, being able to use the allied health workforce who often has much more interaction with the individual than the medical workforce to respond to these changes early, I think is critical. So watching that with great interest. I mean, looking at the challenges we face in home care in Australia, those sort of things would really make life a lot easier, enable us to triage our limited workforce more effectively to provide better service.
Well, you probably remember, George, our very first episode, one of the hot topics we had was the NHS had announced that they were investing in a virtual physio clinic, an AI physio clinic. And I just checked, and a couple of months ago, so it was early January, NHS Lothian in Scotland, they've actually become the first NHS organisation in the UK to introduce this AI clinic to patients across various community healthcare settings. So it does seem as well that the NHS here are really looking at how they can not just invest in AI in traditional senses or things like scribes, but actually looking at how they can actually triage care and provide care. So that AI physio clinic is a thing now. It exists.
Interesting. Eventually, they had a centralized service which enabled them to scale that out to all the other trusts. Oh, wait, that's been cancelled. I forgot about that. But interesting you mentioned Lothian. Lothian was actually, when I was working at Intel, Lothian was one of the very first NHS services to trial some really innovative technology back in the day. So I guess being in Scotland, they have that opportunity. The interesting thing is that we actually did a video back then with the Lothians NHS service, and we had to use subtitles because the Scottish accents were so strong that we couldn't understand what the patients were saying. They did some really interesting stuff.
Very cool. And what about Hinge Health? Have you had any experience with them?
Look, I've been watching them with interest because, again, recognizing that there's a big chunk of healthcare that is currently very, very inefficient because of the requirements to have people travel to a physiotherapist, spend time in a practice, get some exercises given to them. They spend 30 minutes with a physiotherapist and then go home and come back 2 weeks later. And in those 2 weeks in between those visits, they're supposed to be doing exercises and continuing evaluation, but no one's there to watch them. It's too expensive to go back and see the physio every day. So the fact that they can now digitize some of that experience, I think, is really interesting. I had a knee injury recently and I had to spend some time with a physiotherapist, and they give you a piece of paper with some exercise and they show you, but You got 15 minutes in there, and then you go home and try and remember what you do and get inside how to do them. So I think it's great. Interestingly, again, going back probably 2 decades, there was a project out of the University of Queensland looking at virtual physiotherapy. And that was back in the days when cameras were expensive and were really rotten video capabilities. So the concept itself isn't new. It's just another demonstration of how, with the advancing of the technology and the addition of things like AI, so you can actually measure range of movements without having to put a big protractor up against someone's knees. You can use video to do those sort of things. The interesting thing about Hinge Health, is that they've actually done some research. So there's 19 peer-reviewed papers which show significant improvements in pain and mobility. So it sounds like they're doing all the right things. They've demonstrated effectiveness. They've demonstrated efficiency. They talk about a 95% decrease in the amount of human hours required to deliver care. 20 times more patients can get access to the same service in that time frame. I think those sort of things are real benefits. So the IPO is interesting. So they provide services to employers and insurers rather than direct to consumers. And hopefully it doesn't go the way of some of the others that sort of, shine bright like a diamond and then disappear.
That's right. Well, good luck to them. And of course, to all the investors that finally going to get a payday. Yeah, but it was great to see the digital physical therapy. I hope that works. And like you said, the B2B to C model is interesting. And of course, that makes sense in America where companies like Walmart, companies have massive big workforces and an element of manual labor to their work as well. It'll be interesting to see how they could scale globally by modifying that business model as well, because that would be needed in some places. But yeah, good luck to them.
Very interesting. Like I said, we discussed the NHS once. I mean, physical therapy is effective, but it requires commitment and continuing monitoring.
Yeah, it's behavioural change.
Yeah, and that's been the biggest challenge. I don't know if you've ever used them, but going to a physiotherapist here isn't cheap, or usually not covered by Medicare. And again, it's that time in between. They can show you how to do the exercises, but it's continuous treatment which brings the benefits.
Okay, well, time for a quick break, George. And when we return, Pulse Potties, we will be bringing you part 2 of our chat with Dr. Google herself, Dr. Karen DeSalvo, Chief Health Officer at Google.
Excellent. Looking forward to the second part of that. That was a great interview.
We're back. Now, for those who are new to Pulse, welcome. We are so happy you are here. But also, I wanted to let you know that what you're about to listen to is part 2 of our discussion with Dr. Karen DeSalvo, Chief Health Officer at Google. Now, part 1 was in our previous episode, so you might want to go back and listen to that first. We recorded this chat with Karen in late 2024. So now let's pick things up again with Karen DeSalvo.
So going back to the turn of the century when electronic medical records were the real buzz, and that's how many of us got engaged with digital health, one of the major complaints physicians, nurses, a lot of care workers had was how the tools didn't align with their needs. Their workflows were disrupted. Their tools were designed for capturing data for non-clinical purposes. What are you guys doing to make sure that clinicians collaborate with your design team so that the tools you design are designed to facilitate their workflow, meet their needs?
I have a few reflections about the electronic health record era and especially the early days. And you sort of captured the sentiment. And I think part of the reason for that was there wasn't user-centered design. And also when we were entering data into the electronic health record, it was kind of going into our database, in your clinic's database, but there was nothing coming back. So the ROI was very intangible and more tangible maybe to the billing department than to the actual clinicians, which I think makes the era that we're in now of generative AI so different. It's one of the reasons probably there's been so much uptake of these new models, whether it's for helping you plan a birthday party or helping you review the literature. They are more capable of returning that investment. So as you put in the time and the work, it's easier to get some help. Essentially, it augments what you do. It's not a drain on what you're doing. In between all of that, I think is just what are the tools that we can build that support clinical practice, that support the clinical encounter, that support things like a tumor board. And I'll say that we at Google very intentionally have doctors, nurses, clinical psychologists, pharmacists who are part of the team across the company that are at the elbow of the engineers and the designers so that they are a part of not only building the tooling because it'll make a difference in people's health, but also what's the workflow look like? And we have some really good examples of how we've done that work very deeply when we're building software as a medical device, like for mammo readings. Get into the clinical environment, go into the reading room with the radiologist to understand how the tooling might be more useful. Well, sort of fast forward to today, I think it's not only because of pace, but because the scale of what clinicians want to do around the world, we're very much count on our partners to augment that. So we'll call it a wet lab. Like we'll build a thing and we say, this looks like it's going to be really helpful to do. I'm going to use tumor board as the example. If you wanted to review the literature and sort of understand if it was going to match up, if you find any trials that'll match with supporting cancer care delivery. But then we need a partner who really runs hospitals and actually has real tumor boards. And so in that case, for example, we're working with Princess Maxima in the Netherlands, and the clinicians there have been using Gemini to review the literature, to find clinical trials that might be appropriate to match up with the child that they're going to present at tumor board, and then use that to accelerate the discussion, shorten the timeline to finding relevant clinical trials. They've seen things in those conversations where a clinician will say, I've tried that therapy for children with this kind of cancer before, but it didn't work. And one of the things, for example, they've realized is that Gemini can find all the published literature, but people don't often publish negative studies. So I just think it's a great example of how the humans who know the real world and what they've tried and what didn't work, but it may not show up in the literature, and Gemini is only going to know what it sees in the literature. But together, that helps to make their work better. And so that's an example of how we really are counting on our partners to say, yeah, it works in this way. And this is how, with human in the loop, those things are improved. I have lots of examples from across the planet, but I think as we move into this new era of how we're going to use technology in practice, we're going to less and less be staring at a computer. We're not going to type at a computer. It's just like, it's going to be talking to us. It's going to be interacting, but hopefully it's going to reduce cognitive load and make that clinical experience feel much more natural and bring back a lot of humanity, but also make it happen in a way that is more bringing better evidence right to the bedside, and then helping the patient kind of walk away with that knowledge also. That's another part of the work that I get excited about seeing. So yeah, EHR, thank you. Great. Build a foundation. I'm on to the next thing, which builds upon that. But I think it's going to feel, and it already does, so much more helpful to clinicians than the EHRs did.
Excellent. I'm a big Star Trek fan, so the emergency medical hologram on Voyager, I actually asked Gemini the question, how does it compare with generative AI? And there seems to be a lot of things in common. So maybe the Star Trek is really what's going to drive our innovation.
And you might have seen that we just recently announced a next iteration of a model we call Astra, which can see and hear. And we don't have medical use cases for it. There are other use cases that we've talked about, like for gaming. But you can also, start to use your brain to imagine what's that like when the model actually is contextualizing the clinical experience with you as the clinician or as the patient. If you're looking together at the film, at the X-ray, Astra's also seeing it and might be able to walk away with the patient as their advocate and remember some of the things that the doctor said. That's not here today, but you can envision those are the kinds of exciting things that I hope we start to manifest. It becomes an advocate. It becomes a part of that health team that not only has the memory and you can chatbot with, if you will, but it is contextualizing.
It's so good. And we've talked a lot on the pod already about the growth in AI scribes and medical scribes, and the idea that as a tool, and it's a very basic tool in comparison to the Star Trek stuff that we will soon be seeing, but it enables the ability, if you want, to create a patient version of the results. It's still got all the accurate information, but maybe uses less Latin jargon that, means something to doctors, but not necessarily to patients. So yeah, we're looking forward to that. On the patient side of things, Karen, and obviously you've said that this has been something that's been with you pretty much since the early days of your medical training. How do you see the future of patient engagement with digital tools enabling that engagement in their own health and health status?
I think we've talked about this before, actually. I think that technology and what comes with it stands to really bring a lot more power to patients, which I'm a big fan of, because knowledge is power. And most of us don't know a lot about our own health. Most of us forget what we're told in the doctor's office or by the home health nurse or the pharmacist. So having that extra advocate brain knowledge with you as your health agent across your journey is going to hopefully not only make people know more, feel more agency, but also just honestly have more power in their own health journey. And I think it will make patients, in some cases, be more citizen scientists. We've already seen a few examples of that where people, because of the Gen AI, able to get pretty smart about their own conditions and bring new knowledge to their caregivers, which can be uncomfortable sometimes for a clinician. On the other hand, it's really important that we as doctors keep our hearts and minds open to new knowledge. And it may be that Gen AI is going to help find clinical trial that we didn't know about or that's ongoing somewhere. Those are examples of where I think that there's some good potential to really bolster the patient's role in their interaction. I do think also Gen AI is going to, at least my hope is, it's going to help people from becoming patients. And the really significant way that we think we can help the most people most is through prevention. And for a lot of us, that's just, I need to get my mammogram, but I can't figure out when to schedule it. And I can't remember the phone number to call or whatever. We're all going to have our own chief of staff / agent that's going to be able to navigate and manage that stuff for us very seamlessly. And we won't even have to push it because as they get more autonomous, if we allow that, they're going to do it for us. And hey, your mammogram's next week and I've arranged the car and all the things and ordered your old records to be there for the radiologist when you arrive. And it's on your calendar and like all those things, all those little steps, those tasks that we have to take in our health. And so much of prevention is just about that, just the burden of having to make it all happen. So as a primary care and public health person, I get very excited about thinking of all the ways that that's just going to help with screenings and prevention, but also just helping us all do the right thing, make that the easy thing, take the stairs, remember our medication, choose the apple instead of the cookie. I don't know if that'll ever happen.
That's it. Maybe the science will need to change the texture of apples, so still healthy. Fan of apples and cookies on the pod, so in moderation.
But that does highlight a challenge we do have because we often talk about our healthcare system being a sick care system, a reactive system, not being a preventative care system, and how we build prevention into our daily activities includes a whole bunch of things around literacy and health literacy and all those sort of things. So you touched on a few things there, but I mean, obviously this is a major focus coming from your public health and primary care background. What other tools do you see coming into place through Google or through your multiple partners take us away from this reactive care model to a predictive, preventative care model where we're avoiding sickness and going forward? I mean, there's a lot of discussion now around longevity and how we can, almost avoid death. What are your thoughts about how tools can take a role in that space?
Well, the little thread that you said of literacy, and I did want to make sure before I get into prevention again, that I underscore how important it is that as we're deploying these tools, building them and deploying them, we do it with equity by design. And for us, that's a basic tenet. It's one of the teams that I built when I first got to Google was a health equity team. We have inclusion teams that think about product. I knew we needed specialized health equity talent. And they have a big charge in front of them because equity isn't just about, for example, the way we think of it in the US, black-white differences. There's so many axes upon which we have to consider health equity and disparities and inclusion in Australia. You guys know this well. And honor it and respect it. I think the work of thinking about prevention is important tied to that because very often it's lower resource communities or communities that maybe have linguistic barriers or transportation barriers, have other reasons that it's harder for them to get in, not only for care if they already have chronic disease or have a significant condition, but just for prevention. And that's just true all over the world, whether you live in rural Indonesia or if you live in New York City. So the technology then built with equity by design, thinking about what are the ways people will interact with, receive that technology, what are the ways that we want to as a company make it so that, for example, a model can work on device, offline, so that people don't have to be connected to a data center or even to a data plan in order to do some of the self-care work or to receive some of the care work that we do. So as we go along this journey, you'll see that that continues to be important. An example of how we're doing this today that's less Gen AI oriented, but more just basic AI and technology is an effort called Open Health Stack, where we've been working with the World Health Organization and local community organizations like Jacaranda Health in Kenya, where often it's a community health volunteer or some worker on the front lines that needs help with upskilling, needs access to evidence-based guidelines, sometimes in the moment, whether it's for maternal care or for childhood diarrhea. And WHO might have that data somewhere, but you're not always in a place where you're going to get it. So Open Health Stack aims to work with local organizations so they can build an app easily on the phone that will connect with the right ministry or the WHO guidelines and work offline for documentation for the community health workers so they can document the care visit without needing to be connected to a data plan in the moment, and then they can upload it when they get back. We've got more than 10 million people around the world who are already receiving services because of that kind of technology. And it's just the beginning because there's 3 billion Android phones on the planet. So the more organizations use it and start to especially think about that as a added tool in the field. You don't need a computer and you don't need like all the bells and whistles. Sometimes it's just something kind of straightforward like that. So that kind of idea of understanding what are the needs for low resource communities, no matter where they are on the planet, what are all the other kinds of ways we want to think about inclusion will be important as we're working to deploy Gen AI, including the ways that we think about training and building the models. And we've published on some of those areas, George, and there may be some more information people could find on our website, health.google, about ways that we've thought about equity and things like skin conditions. And it's like we've talked about in other ways, as the Gen AI models get more sophisticated, it's the step change in the kind of work we need to do, because like when the model starts to see you and talk to you, it raises, oh, should we be checking the models for things like implicit bias? It's always on our mind. And I'm actually honestly really proud with how the teams have thought about it. And we're starting to see some really nice examples in the field one of which I mentioned, where we're thinking about equity by design and as we deploy the model or the technology in the field.
Thanks. I think it's very important because, like I said, when we talk about prevention, we tend to sort of sometimes think about those who have the resources and have the capacity to do preventative health. And then you have communities, as you noted, that just don't have the resources available to them. That's really important.
And speaking of those communities, a topic you sort of touched on it in your answer before, but in preparation for this interview, I had a look at a report that you co-authored about the United Nations Sustainable Development Goals, and we will put a link to it and to the other papers we've mentioned in the show notes. But according to that report, it's not good news. So 80% of the Sustainable Development Targets have deviated, stalled, or regressed. Only 15% are on track. So what are your thoughts? What do you see happening that are contributing to improving access to healthcare in these underserved regions? Because obviously, and you've mentioned, the importance of equity, but I guess in these underserved regions, they have even more challenges against them.
The Sustainable Development Goals are such an important way that globally, all of us can see how we're moving forward in population health. And, the definition of public health is what we do together as a society to create the conditions in which everyone can be healthy. And I think, as people would see in the report, it's an example of how Google thinks about how it can lean in to health. We have an all-of-company approach. We build health use cases into our products. We have research teams that are thinking not only about how it's going to support and improve things like AI overviews, but how we're going to work with external partners to make data and information available so that they can know how with the progress, so that they can begin to do some anonymous mapping of where access points are in the community. And an example of ways that we've worked, like the UN in this, was with data commons, where we used some of our AI technology to help scrape publicly available databases and use that to accelerate and improve the way the UN can follow the SDGs. We would also, and we do, work with the World Health Organization on information amplification, information as a determinant of health, on some of the tools I mentioned, like Open Health Stack, and also on how to do upskilling of AI in local health organizations and in local communities. Beyond that, in the product space, we have ways that we're even think about maps, making data available, anonymized data available, to do something I mentioned, like we called GeoFM as the model. And it's a way that communities can track access to sometimes the social drivers of health, like food access, but also use it to understand transportation access to things like sites of obstetric care. So we would step back and say, SDGs aren't going right. We have a role to play with the broader community. We'll work with the big global organizations in the space where we can, helping to provide data, helping to provide tools and technology, and then just also working to advance communication and education. And there's a fourth kind of big stream, which is, how can we help with community resourcing? That's very often .org, which is our philanthropy that works with local organizations, NGOs, and communities to try to, again, build durable skills and tools and technology that's going to help them to advance the broad goals. But it is worrisome that we, as a world, we aren't making as much progress as we need to. And by the way, I mentioned a couple of times the social drivers of health. Even though we think about for medical at Google, we talk about our 4Ms: metabolic disease, malignancy, maternal health, and mental health as the condition areas of priority. They're reflected in the SDGs. We believe in the WHO definition that it's about physical, mental, and social well-being. And so what we can, for example, with maps, help contextualize people's health, air quality, et cetera, exposure. So ways that we can also step out of that clinical environment, but think more broadly of how can we help inform what's happening in people's health in that broader definition that matters to public health around the world. We want to contribute.
We have a lot of listeners, Pulse Potties. It's a podcast and it's called Pulse, so they're Pulse Potties. It's funny, actually, I see people in real life and they refer to themselves as Pulse Potties and want to know where they can get merchandise. So I'll have to think about that for 2025. But anyway, so there's a lot of them are actually in the startup ecosystem and that innovation economy. And I know that Google offer lots of programs for startups. So things like the Growth Academy, and you've already mentioned Open Health Stack. So what should startup listeners know about what they should check out that Google can offer them?
I'm going to provide a link that you can drop in the notes that is sort of assembly of all the ways that startups can get engaged with Google. We know sometimes it is hard to find the right door. And like many places, we have multiple doors. We in particular have groups like Google for Startups, we have Google for Developers, and all those have a subset, which is in health. We have ways that the cloud team works directly with trainings and upskilling. I'd highly recommend some of those from Google Cloud because they're leaning in pretty hard to make sure that the whole IT community has the skills and knowledge to not only make their work better, but also to help us. It's a nice virtuous cycle. And we're really proud that most big startups are actually on Google Cloud. So it's a really important resource. And sometimes there are ways that cloud can provide credits, for example, to get people rolling. Some of the programs we have that people can apply for, like Google for Startups as an example, there's also a way that there's some mentorship involved. And sometimes me and my team are involved in that just to provide some steer and guidance for these new organizations. I will say that going back to what we talked about at the beginning, some of the bigger organizations in health around the world think about automating their existing processes with AI technology. It's the startups that are thinking about transformation. So I'm a big fan and I want them to, there's some groups that I don't know if I even call them necessarily startups yet, but they're definitely earlier innovators, like a group called UV based in Japan and one called Dr Lib based in France. They're doing a lot of thinking about this bridging between the patient and the doctor and that communication pathway in a different way than interoperability and PHR, but really making it more fluid so it's easier, especially for patients, but also for docs. So there's some exciting ways that I think people are kind of rethinking the encounter, the exchange, and the work that we do. So we'll drop a link in there from the website that people can look at and get some navigation to get some work with us, if that makes sense.
Thank you. Thank you.
I'm old enough to remember when Google was a startup, so back in the late 1990s. And I remember the transition from those stages from things like Ask Jeeves and Yahoo to Google was transformative.
What's really interesting about being at Google right now, I've been here 5 years. So I was here when we were kind of, big, and then we moved into COVID, and then Gen AI changed everything. It is very much like the company is reflexing our own startup muscles, around agility and sort of test and learn and learning that rapid cycle iteration. Because this is such a cliche expression, but it's like we're renovating our house while we're also throwing our wedding in the house. We have search, but we're also remaking it on the surface. It's a very exciting time for us. And I think it's given us a lot more appreciation for startups and sort of, all the unknown, but all the excitement also.
Must be exciting. I mean, being $1 trillion startup must be very different to being a $100 startup, but it's a really exciting time. And it's interesting because we reflect over the 25 years of Google, the amazing things that have happened there. What does the next 25 years look like? How do we see going forward, in particular around health, but obviously health is part of a broader social domain. So how do we see the transformation go over the next quarter of a century? Not asking you to do much there.
Okay, I can't even think that far out in advance. I'm just going to be honest. However, I will say that for the last 35 years that I've been in medicine, we've had very similar challenges. And just about anywhere on the planet you go, these are the things you hear. It's too expensive. It's inaccessible. workforce is exhausted or there's not enough people, there's too much information, people are overloaded, and just that it's too mass. It's not customized enough for individuals, not personalized enough. Gen AI is so good at solving all of those areas and kind of rethinking it. So I think whether it's in the science space or in the care delivery space or even, the bigger public health financing space, we're going to, I think, find that we can do more with what we have in terms of the people in hand. And we're going to be able to keep people healthier, longer, healthier lives because we're going to be able to be with them. When I say we, I don't mean we Google, I mean the AI products of their choice will be along that health journey with them and navigating but more importantly, anticipating their needs and making the experience more personalized for the every person. And ideally, health becomes more of an afterthought for people. It's not a hard thing that you have to deal with. It becomes built into your life flow. And similarly for clinicians, I think we'll be bringing joy back to medicine because you're going to have a bot that is your best version of yourself practicing medicine and that team around you of that AI capability, but you're still going to also have the human team that you get to work with. So it's going to be this nice, more seamless mix, I think, of technology and humans working together to provide a more customized anticipatory experience for people. And I genuinely believe it's going to lead to more health for everybody on the planet.
I love that. I think you've just given me the title of the episode when it goes to air, Bringing Joy Back to Medicine. Beautiful line. Karen, thank you so much for joining us today and fitting time in your incredibly busy global remit schedule to come and spend some time with us in the PulsePod studio. It's been great having you here. Thank you so much.
Well, thank you guys. It was a blast.
It was great. And I have to say, your energy is infectious. I often describe myself as a grumpy old doctor, but you've brought joy back to my medical life as well. So I appreciate it.
George, another episode bites the dust.
We're flying through these and having fun all the way through.
Yeah, amazing. Now, George, do you have anything that you want to recommend to Pulse Poddies?
Lots have been happening, but one of the more exciting publications which I saw during the time was a publication recently released by the CSIRO, Australian eHealth Research Centre and the Digital Health CRC. And it was a great report looking at the Australian aged care data landscape, which is obviously very important to me currently in my role with Aging Australia. And I do note that the report was co-authored by our good friends David O'Driscoll and Gil Carter. The challenge I had with that report is that it basically landed on my inbox just after I arrived back from a 24-hour flight from Europe, and that's just as I was getting ready for ITAC. So I had a couple of hours to get my head around 120 pages of really good information. And I have to say, I was interviewed as part of that study and with a number of other people, and it really was some interesting work looking at the challenges of getting data into aged care. Interoperability was obviously an issue, heterogeneity of the data system, lack of standards, all those sort of things. But one particular phrase they used in their executive summary really caught my attention and I think is one of the key priorities we need to look at. A coordinated national approach which guides the improvement of data access and use within aged care is essential to a solid aged care landscape for Australia. I think that sort of says it all. So highly recommended. Australian eHealth Research Centre or Digital Health CRC both had it available. And Schmidi was at our conference at ITAC and she spoke to it. And I did have to admit that I cheated a little bit. I took the 120-page document, stuck it in ChatGPT, asked for a summary and used that as my basis. But when I got back home, I started reading the whole document. Some great graphics and a lot of great references. So highly recommended.
Oh, fantastic. All right. Well, I've got a report as well I would recommend, and we'll put links to both of these reports in the show notes. So if your health organisation is thinking about how to introduce, use and monitor AI, then I suggest you have a look at this AI framework, which has just been published by One London here in the UK. They developed this framework to basically remove confusion about how to practically work with AI across different organisations that service the London health and care system. The framework, it's really comprehensive. It covers partnership principles for working across organisations, the infrastructure and, of course, the governance that you need, workforce upskilling and engagement with the community, or how you communicate the use of these tools and how they're incorporated to the people that you serve. And there's also use cases in there. So it might be of interest to some of our PulsePod listeners who actually are thinking about how to do this as a starting point. Don't reinvent the wheel and have a look through what One London have put together. So yes, we'll put a link to that in the show notes.
got to love a good framework, because as we look at this complex area of AI in healthcare, understanding how we do it in such a way that we can continue to do it, not just have a whole bunch of trial and errors, I think is important.
That's right. And of course, if you are in England at any stage from overseas, or if you're a local, I know the people I had dinner last night hadn't been to the Wellcome Library. So here's my second shout out to the Wellcome Library to go check it out. It's a pretty cool place. All right, George, that's a wrap. Could you please read us out?
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Big thanks to everyone for listening. Make sure you subscribe, follow and rate us wherever you get your podcasts. And don't forget, you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear from what's on your mind. All the best, everyone.
Thanks, George. See you, everyone.